Hi, good morning, and welcome to Grand Rounds. We're really thrilled to be celebrating the contributions of our house staff to the medical literature and to our understanding of how to care for patients. It's always a tough decision to try to decide who gets the honor of presenting today. And there's literally dozens of house staff that we could have selected for this honor. But we chose 6 speakers today, and they're going to be addressing things that are important to all of us: healthcare disparities in how we care for patients with CML, how we do getting patients back to the outpatient setting who are struggling with mental health issues, what we are doing around heart failure. So things that are really important to everyday practice of medicine and also to our broad understanding of how to move forward as a profession. We are so privileged to have Dr. Gina Osorio leading the efforts around research and contributions to the literature in our residency program. Gina is a passionate mentor to anyone she touches in the training program, and it's such a privilege, as I say, for us to work with Gina. And I'm going to pass the podium to her now to introduce our speakers.
Okay, so thank you first of all to all the mentors who are here as well, which I'm going to be mentioning throughout the presentation, because I think that many of this, I think the residents would agree, would not be done without the mentorship and guidance of many of the faculty who are here and present. So just to move forward so that they have their due time. These are our annual data that we like to present at this time. So for the academic year of 2018-2019, there was much more robust representation. Just so that you guys realize, last year was about the 20 central conferences. Now we're at 38 conferences that were presented. There were 11 oral presentations throughout this academic year done by our residents, 94 poster presentations. And it's not just presentations at multiple conferences, because I'm going to list them because it's national and international conferences that I'm talking about, but also publications. So these are individuals that in their 3 years of residency, or even their first year of residency, very rigorous, as we all know, have been able to publish during this period of time. So 48 peer-reviewed articles and 5 book chapters during this time. And I just want to mention that a lot of this data was organized, and I say meticulously organized, by our chief resident, who is finishing up this Monday as one of our chief residents. Dr. Sean Leap is going to be staying on to do cardiovascular fellowship here at St. Luke's West. So in terms of conference representation, I mentioned throughout the nation and globally. So American Heart Association, Chicago, American Society of Clinical Oncology, that was also in Chicago, ASH in San Diego, California, American Society for Transplantation Cellular Therapy in Houston, so more specialized, American Thoracic Society that was just held in Dallas, Annual European Congress of Rheumatology that's in Geneva, Cardiovascular Research Technologies that was in Washington, D.C., Digestive Disease Week that just was held in San Diego, California, EuroEcho that was held in Italy. Again, multiple conferences throughout. Locally as well, we have one of our presenters that's going to be presenting at the GME Annual Research Day that's going to be held in the next week. The National Kidney Foundation clinical meetings. New York State Academy of Family Physicians that was held in Rochester, and then we have Society of General Internal Medicine that was held in Washington, D.C. just in the last few weeks. So again, multiple meetings throughout, and it's not just them presenting, they're also receiving recognition for these presentations. So Dr. Sridevi Rajiv actually just received, and I was honored that she received the American Society of Hematology Honors Award, so she's going to be getting a stipend to continue her research for this next year. Dr. Bertin Sergero receives scholarships at CHEST and ATS. Dr. Karan Saad received Young Investigator Award at HA, so received by the American Association of Cardiologists of Indian origin. He received the top oral abstract at the Cardiovascular Research Technologies. It was actually inducted as a faculty for that meeting, and received the Star Research Award at the Society for Critical Care Medicine. Dr. Ilya Verhian has also received poster distinction at the Digestive Disease Week, and as well as the Mount Sinai Quality Division Award and American College of Gastroenterology, 2 outstanding poster awards there. Multiple authors. Again, we spend an extensive amount of time reviewing all the submissions that our residents have given us throughout the year in terms of academic work that they presented. And we went through it for many, many hours, I would say, even days. And so I want to make sure that everyone gets their credit because there was a lot of work done this past year. And it was very, very hard to select the 6 individuals who are going to be presenting in the next hour or in the next few minutes. So just multiple authors. The actresses that I want to highlight are the ones who are graduating actually tonight. So we have graduation being held tonight in this location. Anyone here is welcome to attend, please. So all the asterisks are individuals who are graduating. And again, this actually held multiple slides, but multiple authors throughout that I want to make sure they recognize. And it's throughout the years. It's not just the third years, but it's also first years who are here and second years. So again, just to not take away their time, I'm going to start with Dr. Warchek. So Dr. Warchek, I should say Dr. Warchek is by how I call him, but Dr. Zezorchek, he is going to present a poster that he presented at the American Heart Association Quality of Care Outcomes Research in Cardiovascular Disease. This was held in April in Virginia. Multiple colleagues here who are current residents and under the mentorship of Dr. Tamis Hall and Jacqueline. So he's going to present the impact of social demographic factors on 30-day readmission and death in patients with acute myocardial infarction. So this is an ongoing heart failure liaison initiative at St. Luke's. He is a graduate at Medical University of Warsaw, and he's going to be applying for cardiology fellowship this year. Go ahead.
Gina, how are you managing questions?
Oh, so yes, thank you questions. So we're very set on time. So we are going to limit each presentation to 10 minutes of total time. So questions will be right after each presentation because of clinical duty, some individuals have to leave, but we just have to be mindful of the time.
So, as you know, I'm Wojciech, and I have a great honor to present on behalf of many people involved in the Heart Liaison project. And I will be talking about the impact of socioeconomic factors on 30-day readmission and death in patients with acute myocardial infarction. It's estimated that around 16% of patients admitted with acute myocardial infarction are readmitted to the hospital within 30 days. And it's estimated that the annual cost for these readmissions is around $1 billion. So most predictors and most scores developed to estimate the readmissions are based purely on comorbidities, including the Medicare CMS score. So our intention was to investigate the socio-demographic factors which could be contributing to readmission and death as well. So we analyzed patients who were included in our quality improvement project. Our quality improvement project was aimed to improve the bridging of patients being discharged with myocardial infarction. So we provided a 30-minute long education about risk factor modification, about lifestyle after myocardial infarction. We created an educational pamphlet, which we handed to patients. We also gave them a phone number they could call at any time with any questions. We provided a 48-hour phone call to make sure that they are taking their medication, that they know where are their appointments. And we also ensured a 1 to 2 week follow-up appointment. So during those encounters, we also collected data on baseline demographic factors, their comorbidities, disease severity, hospital course, also on the quality metrics, and the socioeconomic factors based on a BOOST initiative. Which was also a recommendation of CMS to do, but was not introduced before in any model. So from those variables, we screened all those variables with univariate analysis, and we picked variables with p-value less than 0.2. And we picked the most relevant variables and then included them in the multivariate regression model. So here you can see the baseline characteristic of our population. We screened more than 2,000 patients. Among them, more than 700 had myocardial infarction. It was all within realm of 2 years. And we were able to include in our quality project 208 patients. So as you can see, 33% of patients were female, the average age was 65, which reflects the population of American patients with AMI. Those two variables were also significant predictors of readmission, so the female sex and older age. More than 50% of patients were white, almost 40% were Hispanic, and most of patients had Medicare and Medicaid insurance. None of these factors were significantly contributing to readmissions. As far as the comorbidities, we found that insulin-dependent diabetes mellitus, prior heart failure, chronic kidney disease, and end-stage renal disease were significantly contributing to increasing the risk of readmission. We also looked at psychiatric comorbidities, but those were underrepresented in our sample, so we cannot claim any correlations from that population. We didn't find any correlation with smoking and readmissions. So finally, here you can see some of the socioeconomic factors that we have examined. We looked at the language proficiency, and this we estimated by asking questions about the language preference, also about how people feel they understand English. And we couldn't see any correlation with readmissions and death, though the caveat is that almost all the patients received translation if that was required. So other factors that we looked at was employment status, and patients who were employed had lower chance of readmissions. We also looked at education. This was not related to readmissions and death. And then we found that being married or having a domestic partner also correlated with lower risk of readmissions. So finally, this is the model that we created. It included age, female sex, chronic kidney disease, insulin-dependent diabetes, socioeconomic factors including employment status, being married or having a domestic partner, and need for medical help. It was a subjective need of medical help. And we also looked at those many factors that I mentioned, but I could not present today. Among presentation and disease, we looked at presenting symptoms, at ejection fraction. We looked at the vessels that were involved, number of involved vessels, interventions. And among all those factors, we chose the hospital score to include in our model. We also looked at complications, and we decided to include in-hospital heart failure with reduced ejection fraction. And then we looked at many quality metrics, and among them we decided to include the presence of the second antiplatelet agent. And in this model, two independent predictors, so being married or having a domestic partner, was an independent predictor of lower readmission rate, almost 80% lower readmission rate, and a high hospital score was associated with almost 8 times higher readmission rate. So this is the receiver operator characteristic curve for our model with a discrimination of 0.87. So the official Medicare discrimination was 0.65. And most of the models actually have discrimination around that level. So to summarize, we found that socio-demographic, socioeconomic variables have significant impact of 30-day readmission and death. And we believe that having a good analysis of those factors and a second look before discharge on the socioeconomic background can help identify vulnerable patients and maybe provide them with additional assistance. So please let me know if you have any questions.
Any questions at St. Luke's?
Dr. Steiger has a question.
Good morning. I enjoyed your presentation. I'm particularly interested because I similarly are looking at readmissions, but specifically looking at COPD readmissions, which is like acute MI readmissions. It's of great interest to all of us throughout the system and beyond as it affects the bottom line reimbursement. So one of the things we have in common in looking at COPD and MI readmissions are socioeconomic factors, comorbidities that are both play a significant role in increasing risk of readmission in COPD population and acute MI population. So I have two questions. And these are questions relating to determinants of length of stay in the COPD population. Did you look at length of stay and severity of illness during admission? And do you incidentally know what the readmission rate is for the patients who went to rehab, with the hypothesis being that maybe those patients, because they're going to rehab, they have decreased readmission?
Yes, so we looked at the length of stay. Length of stay was significantly associated with the risk of readmission. Length of stay is a part of the hospital score, so that's why we haven't included it in the final model. The second question, unfortunately, we have not included patients who were discharged to rehab in our project. The reason for that was that we felt that actually they are at lower risk of readmission. They already have some continuity of care because of being discharged to subacute rehabilitation center. But actually, with a new cohort, we are enrolling those patients in our project as well. So hopefully, we'll have answer for this question as well. Thank you very much.
So I forgot to mention that Wojciech is one of our second years. So our next presentation is actually from one of our first years, who's almost going to be a second year. So Dr. Binbin Zhang, so he's going to present an oral presentation. So just to be mindful, he was selected 9 out of 300 abstracts that were submitted to present as an oral presentation at the annual GME Research Day over at ICON. It's going to be held on June 7th. So he's a graduate of the Universidad Autónoma de Madrid Facultad de Medicina, and also did a master's in molecular oncology at the Spanish National Cancer Research Center. As you can guess from his talk, he has a high interest in hematology and oncology and will be applying in a few years. So he's going to talk about insurance status and healthcare disparity in patients with Hodgkin's lymphoma before and after the Affordable Care Act, or some might know as Obamacare, a SEER database study. So this is in collaboration with multiple, some colleagues here at St. Luke's West.
Thank you, Dr. Sir, for your presentation. Right, so I'm Binbin Zhang. I feel really honored to be here, to be able to be selected here and present the results of what is months of teamwork. And of course, special thanks to Chen, who's graduating today, and Charles from second year. So our team, we're interested in elucidating the impact of the insurance status and how that may lead into healthcare disparity in patients with Hodgkin lymphoma. And we'll be comparing the data from before and after Obamacare. Now, a little bit about the epidemiology of the Hodgkin lymphoma. There are two data that I would like you to keep in mind. And one is that most of the patients, this disease is really most commonly diagnosed in young patients aged 20 to 34. And also the overall disease-specific survival at 5-year rate is about 85%. Now we have to take this 85%, this number, with a grain of salt, because in addition of all the prognostic factor that we know, just one specific prognostic factor that we kind of all know, but we never talk about it enough, and that's really the access to healthcare. And in a country like United States, the access of healthcare is really determined by the type of insurance you have. And here I presented the data from the U.S. Census Bureau, which shows the rate of uninsured population throughout the year, and we can see that there's a consistent uptrend of populations that are uninsured up until 2010, 2011, and after that revolt of Obamacare, there's actually this drastic decline of the rate of uninsured population. So our team was really interested in two things. One is we want to know what's the effect of different type of insurance in the disease course of patient with Hodgkin lymphoma, specifically in terms of diagnosis, treatment, and overall outcome. And secondly, we want to see what's the role of Obamacare in this kind of disease in these patients. Now, so in order to study a national trend, we used a national database, in this case, SEER Cancer Registry. We retrieved data from this database of patients with Hodgkin lymphoma aged 15 to 64, and we stratified them into 3 groups: privately insured patients, patients Medicare that were underinsured, and uninsured patients. We included patients from 2007 to 2014 because at the time of data analysis, 2014 was the most recent one, and we just divide that data from before 2010 and after 2010, and that would be because that's the year when Obamacare was approved. We excluded patients with insufficient follow-up or unknown insurance status, and in terms of analysis, we did chi-square for categorical variables, and we did Cox regression for survival analysis. And we also used backward selection to select those covariates that we wanted to include in the final multivariate model. So with the table 1 and with this whole bunch of numbers, the core message is that patients that are underinsured and uninsured, they are most likely to be under the age of 39, which is as you may remember, that's coincidentally, that's the peak of the incidence of Hodgkin's lymphoma. And also they're more likely to be Afro-American or Hispanic male coming from a family with a low annual house income, and also they are more likely to be located in the southern part of the United States. Now, this is the table 2 with the most interesting data from our study. Just one thing, this is just one table, however, it contains data from 3 different independent multivariate models that assess the correlation with insurance type, with stage, treatment, and mortality. And we also compare the data from before and after Obamacare. So in the first part of the table, we can see that the insurance status, regardless, does not really have any impact on the disease stage diagnosis, regardless of the year of diagnosis. It doesn't matter if you were diagnosed before or after Obamacare. Now, in terms of treatment modality, we can see that Medicare under and uninsured patients, they are less likely to receive combination therapy in comparison to those patients who have private insurance. And also in the pre-Obamacare area, patients with Medicaid, they were less likely to receive single chemotherapy or radiotherapy in the pre-Obamacare area, and not so much in the post-Obamacare area. Now, in terms of overall mortality, we can see that being under Medicaid and uninsured were statistically were independent predictive factors for worst outcome in the pre-Obamacare area. In the post-Obamacare area, unfortunately, our cohort wasn't powered enough to reveal any statistical data. However, if we pay close attention in the Medicaid group, we can see a trend towards a better survival outcome, and also that there is a statistical difference between the pre and post Obamacare area, being that the confidence interval of the of the hazard ratio in post Obamacare area doesn't really overlap with that of the pre Obamacare area. And of course, all these data were adjusted for possible confounders, including age, gender, histology of the disease, and the region, among others. Now, so really the take-home point is that being under and uninsured is really an independent prognostic factor for worse outcome. And these patients, coincidentally, they are more likely to be minority young males, which is specifically where the disease incidence is at its peak. So all these factors combined together, we can see that being uninsured, it can lead to a possible significant loss of productive life. And despite the fact that the study wasn't powered enough to reveal any difference in mortality, we do see a trend towards better mortality in the post-Obamacare area. So, and also the clear role of Obamacare remains to be elucidated, and hopefully within the next year, when we have more data, we can have better answers, and that is if the current administration doesn't eliminate this act. Any questions?
Any questions at St. Luke's first?
Thank you for speaking on a very important aspect of access to care and its maldistribution due to economic factors. So the question is, and this is tongue-in-cheek, is this a strong support for a single-payer system where everybody will have equal access without the horrendous wasteful paperwork that's being done? Would you support that?
Sorry, can you please repeat your question? I'm actually not quite sure. If
I think it's an argument for single payer
available to everyone who needs it, regardless of economic status. A single payer system would accomplish that. The question is, does data support that?
Actually, we don't really have specific data that can support that. And personally, if I may say, since I was trained in Spain where we have universal free healthcare, I really admire that model, and I do believe, as the slogan of the Rand Chelsea Clinic, that healthcare should be a right and not a privilege.
So, and just to challenge you, I think it's important to go back and power your studies such that we can answer that fundamental question. Are you planning to do that?
At this point, we are still at the stage of retrieving the most updated data from the SEER database and update the analysis. So that's a very good question. We should always think about what's the next thing to do, especially in when we are talking about a question as interesting as this one. So at this point, we don't really have any future project, but of course, with a larger, with the Epic Data Warehouse, that may enable future studies regarding to these subjects.
You could simply compare your data with the data from Canada, which is a comparable population and a system that's close to us, so we don't have to worry about disparities between the different countries of the European Union. But that's another possibility.
That's an excellent idea, actually. Thank you.
I enjoyed the presentation. A comment and in your response. I fear that universal health coverage, single payer, may not be the answer, because with respect to the lung cancer model and access to care, increasingly in rural areas, there is no available tertiary resources, healthcare resources, to provide the kind of high quality, highly specialized care. And how would you address that?
So right now, due to the fact that we picked Hodgkin's lymphoma and also due to the fact that the mortality of this type of cancer is quite low, it's really hard to yield a statistically significant results, even with the whole national database from the US. Of course, in the future, if we're studying other type of cancer with higher incidence and higher mortality rate, we may look actually into geographical differences of those data. But of course, that'll be a very interesting future project to do. Thank you.
Okay, so our next presenter is one of our current second years, so Dr. Faris Hadidin. He's going to present a project that he worked with multiple colleagues in mentorship under Dr. Patel and Dr. Gulian. So the prevalence and predictive services to hypertension, high-risk overweight, and obese hypertensive patients, a cross-sectional study based on the 2017 ACC/AHA hypertension guidelines. Dr. Hadidin is from the University of Jordan Faculty of Medicine, and he's going to be applying for cardiology fellowship this year.
Thank you, Dr. Osorio. Good morning, I'm Faris, a second year intern medicine resident. First, I would like to thank our residency program for selecting this project to be presented today before the Department of Medicine. It's a great honor to me and to all my colleagues who participated in this project. As you can see, it was supervised by Dr. Patel, our Associate Program Director, and Dr. Argulian from the Cardiology Department. So as we all know, the definition of hypertension has recently changed, and now we diagnose it based on blood pressure cutoff of 130/80 instead of the 140/90. The definition of resistant hypertension is blood pressure that's not at goal despite maximum dose of 3 blood pressure lowering agents of different mechanisms. One of them should be a diuretic agent, or the requirement of 4th agent or more in order to control the blood pressure. Now, resistant hypertension has different definitions based on the context of uncontrolled blood pressure. If it was detected at the office, then we call it apparent treatment-resistant hypertension. If the apparent treatment-resistant hypertension then is confirmed with a home blood pressure measurement in an adherent patient on optimal doses, we call it true resistant hypertension. Otherwise, we call it pseudo-resistant hypertension, which is basically the opposite of true resistant hypertension, and it's usually attributed to either white coat hypertension, non-adherence, and suboptimal doses. Those are the new definitions of resistant hypertension, relatively new. Now, the prevalence of resistant hypertension based on the older cutoff of 140/90 was 8% in the general hypertensive population and 13% in the treated hypertensive population based on the 140/90. Now we don't know the current prevalence with the change in the hypertension definition to 130/80. But the ACC/AHA report in 2017 predicted around 2 to 4% increase in the prevalence. And to our knowledge, there are very limited studies, if any, that look specifically into resistant hypertension in obese patients. So based on those 2 points, we decided to conduct our study in order to answer 2 questions, which were the aims of our study. First, what's the prevalence of resistant hypertension in high-risk overweight and obese hypertensive patients based on the new cutoff of 130/80? And second, what are the predictors of resistant hypertension in these patients who are obese and hypertensive? So it was a cross-sectional study. We included high-risk overweight and obese patients with hypertension, defined as BMI between 27 to 29.9 plus 1 or more obesity-related comorbid conditions. This is based on the Obesity Task Force report in 2013. This is a new category in overweight and obesity of BMI of above 30. It took place at the William Ryan Center at 97th Street, and we identified patients based on visits they had between October 2017 to October 2018. And we used Pearson chi-square to differentiate between the categorical variables, student t-test for continuous variables, and the multiple logistic regression to adjust for confounder when we measured the predictors of resistant hypertension. So this is our study cohort. So during the study year, we identified 1,650 patients with high-risk overweight or obesity, but only 761 of them had hypertension. So those were basically our study population who were actually enrolled in the study. Of them, 86 patients were controlled with lifestyle modifications only. 430 patients had their blood pressure controlled on 3 agents or less, and 245 245 patients had their blood pressure controlled with 4 agents or more, or had uncontrolled hypertension. So they were candidates to have resistant hypertension, but only 104 of them had resistant hypertension at the office. So basically, they had apparent treatment-resistant hypertension. Now, looking at those patients who had apparent treatment-resistant hypertension, and then reclassifying them based on their home blood pressure measurement, based on adherence and their doses of their medications, only 48% of them had true resistant hypertension after confirmation at home. 15% did not have their blood pressure measured at home, and 37% had pseudo-resistant hypertension. Of them, 12% was attributed to white coat, 14% to medications non-adherence, and 11% to suboptimal doses. Now, those with true resistant hypertension were actually 50 patients, were compared with the rest of the study population, and they were more likely to be older. They had higher mean BMI value. They were more likely to be of black race, to have diabetes requiring insulin treatment. They had higher mean A1C value. They had more dyslipidemia requiring high-intensity statin. Also, diastolic heart failure and CKD stage 3 or above. And of course, they were more likely to have more medications on their list because they have resistant hypertension. The other variables such as NSAIDs use, tobacco smoking, alcohol misuse, recreational, significantly different between both groups. So first outcome, which was the prevalence of resistant hypertension in our study population. So we reported a prevalence of 13.6% of apparent treatment-resistant hypertension in the general hypertensive study population, regardless of whether they were receiving treatment or not, and it was higher, 15.4% for the treated hypertensive population of the study. Same manner for the true resistant hypertension, which was 6.7% for the general hypertensive population, regardless of whether receiving treatment or not, and 7.4% for the treated hypertensive population of the study. And for refractory hypertension, which is uncontrolled blood pressure, despite being on 5 blood pressure lowering agents of different mechanisms, one of them should be a thiazide diuretic, and one of them should be an aldosterone antagonist, and they should be taken care of by a hypertension specialist. The prevalences were 0.8 to 0.9, depending on whether the population is receiving treatment or not. We're also looking at the prevalence patterns across different BMI categories or classes of obesity. We found that any kind of resistant hypertension or even uncontrolled hypertension was higher across higher BMI values or across more advanced obesity classes. For example, the prevalence of apparent treatment-resistant hypertension was 12% in class 1 obesity, but was 19.5% for class 3 obesity, which is BMI of above 40. Same did for mean systolic and mean diastolic blood pressure, which was higher for the more obese patients. And this is really in line with all the prior literature, which linked obesity or higher BMI values were difficult to control hypertension or uncontrolled blood pressure. This is our last outcome, second one, which was the predictors of resistant hypertension in our study population. Actually, they're predictors of true resistant hypertension, the one that's after confirmation at home. So on the multiple logistic regression model, we found that after adjustment, having black race, having higher mean BMI value, having diabetes requiring insulin, having dyslipidemia on high-intensity statin, did not actually. Diastolic heart failure and CKD stage 3 predicted true resistant hypertension in high-risk overweight and obese hypertensive patients. So in conclusion, we reported a prevalence of 15.4% for apparent treatment-resistant hypertension in the treated hypertensive high-risk overweight and obese patients with hypertension. The prevalence of resistant hypertension was higher in subjects with higher BMI values, and the predictors for true resistant hypertension were, as we mentioned, higher BMI value, CKD, diabetes requiring insulin, and also diastolic heart failure. Thanks.
Thank you for a very nice talk. I touched upon this, but the usual definition of resistant hypertension is not being controlled on 3 agents, one of which is a diuretic. And I think in your slide, only 30 or 40% of these patients were actually on a diuretic. Is that correct? Can you comment on that?
In the baseline characteristics. So basically, those were not defined as having resistant hypertension. So we had 245 patients who had uncontrolled blood pressure. But the ones who were excluded from the definition of resistant hypertension were actually either not on a diuretic agent or had a diuretic agent that has not been used in the definition of resistant hypertension. So only the ones who were actually on a diuretic agent were included in the definition of resistant hypertension. The others were actually excluded from that. And we have actually a second project that looked into the diuretic agent utilization in hypertension patients and its effect on controlling the blood pressure. Basically, it's based on the all-HAT trial, which showed the efficacy of diuretics, and also the VALUE trial. So we're trying to show that in a different study.
Was there enough data to show you what the outcomes were of this or poorly controlled hypertension? I have to ask a nitty-bitty basic question. I found that clinic blood pressure measurements are notoriously disastrously awful. Nobody adheres to the guidelines. Patients are rushed in from the waiting room, set down, no time is waited, the arm is not elevated level of the left atrium, and then it's taken. And then the other thing is using the launching of the cuff of the morbidly obese. The overweight is less of an issue, but the morbidly obese is really hard to make sure the measurements are accurate. And then finally, who took the at-home blood pressures? Were they trained personnel, the patients themselves, and were the devices different for the different groups?
It's actually a very good question. Measuring the blood pressure at the clinic is a big limitation, especially for obese patients. And even though nurses are trained to take 2 blood pressure measurements, the patient should be rested, but things do not go in perfect way all the time. So that's why the prevalence of pseudo-resistant hypertension was actually higher. Now, for home blood pressure measurement, for our study population, so there are 2 ways to measure the blood pressure at home. either the home blood pressure measurement, which is actually covered by Medicare, Medicaid, where we give the patient the blood pressure machine and then they take several measurements and then we average them, or the one that's actually more preferred, which is the 24-hour ambulatory blood pressure measurement, where it's preset to measure the blood pressure every 15 to 30 minutes and 15 to 1 hour at night. Our patients only had the home blood pressure measurement. So what used to happen during that year is that whenever a patient has uncontrolled blood pressure at the clinic, usually we would schedule them to come in 1 to 2 weeks to have a blood pressure measurement visit with the nurse, and the nurse has to ask about the home blood pressure measurement, and they have the machine, adherence, and what medications they take. Now, this method is not the most perfect one as compared to the 24-hour ambulatory blood pressure measurement, but I think in our study population we had some limitations in our insurance capacities, so that's why most of our patients were actually on just the home blood pressure measurement, which is the intermittent method. So that's why we had higher prevalence of pseudo-resistant hypertension than other studies, because we have high-risk population, which is actually obese and high-risk overweight, just because of the reason of why other cuff is actually small on the hand and these factors.
So Norma, you anticipated my question, so all I'm going to say is thank you, Dr. Braun.
Thank you.
Okay, so our next presenter is one of our graduates, so Dr. Chen Wang. So she's going to present a poster that she presented at the American Society of Hematology back in December. This is the cardiovascular mortality among chronic myeloid leukemia, CML patients, and pre-tyrosine kinase inhibitor and TKI era SEER analysis. So this is in collaboration with a few of our colleagues and a faculty, Dr. Morrow, that's over at Sloan Kettering. She is a graduate of Lanzhou University Faculty of Medicine. She also received a Master's of Public Health and Environmental Health Science focus at Yale University. And she will be continuing on at Mount Sinai as one of our hematology oncology fellowships in another month. So again, one of our graduates, again, is going to present. Thank you.
Thank you, Dr. Osaro, for that introduction. Good morning, everyone. It has been a pleasure and an honor to be here to present my project. I'm Chen, one of the PGY3s. Today will be our graduation day. I'll just briefly thank everyone here. Thank our Dr. Osaro, Dr. Sur, Dr. Androli, and all those leadership attendings. Thank you for your support. Without this, all those guidance, support, and this great platform, we wouldn't achieve so many things in this academic area among our residents. Thank you, everyone. Okay. So today I'll be presenting my project. This has been presented at ASH early this year. So it's about cardiovascular mortality among chronic myeloid leukemia patients in the pre-tyrosine kinase inhibitor era and TKI era. This is from a SEER analysis. So chronic myeloid leukemia, CML, is characterized by the T922 translocation, the Philadelphia chromosome, which is very famous. In the past, especially before 2000, before the imatinib, it's really a fatal disease. It was treated with mainly chemotherapy, like cytarabine, interferon alpha, and stem cell transplant. After 2001, when the FDA approved the first generation TKI imatinib, really the course of this disease has been changed significantly. Right now, about more than 90% of the patient will live just a normal life as the general population. So currently, there are 5 different TKIs has been approved by FDA for chronic myeloid leukemia chronic phase, including imatinib, dasatinib, nilotinib, bosutinib, and ponatinib. Given this, despite this improved overall survival outcomes and people having concerns about this cardiovascular profiles of all those TKIs, especially the newer generations, such as nilotinib and ponatinib, which has a lot of cardiovascular toxicities. So that's why we were thinking, okay, so if there really so many cardiovascular toxicities, will this, those newer generation TKIs really affect the ultimate outcomes of the CML patients, such as their cardiovascular mortality? So this is a retrospective populational-based cohort study from SEER database. We included patients who were diagnosed with CML from 1990, January 1st, 1990 to 2014. We included about 10,000 CML patients aged about 15 years old who are actively followed, the median follow-up about 53 months. So there are about 3,300 patients who were diagnosed before 2001, which we define it as pre-TKI era. And then after TKI, we have about 7,500 patients. So the outcomes we were looking at is mainly cardiovascular disease-specific mortality, comparing the pre-TKI era to the TKI era. And I also look at the standard mortality ratio before and after TKI to the general population. And we use this sub-distribution hazard ratio to kind of calculate the cause-specific mortality. So I'm going to just present the main findings of this study. So this is a cumulative cardiovascular death incidence by year of diagnosis on the left side. The blue is the pre-TKI era, and then the red is TKI era. So you can see actually there's a significant difference. So those who were diagnosed in the pre-TKI era, they had a higher chance of developing a cardiovascular death compared to those diagnosed in the TKI era. And if you look at the hazard ratio, it's about 26% more likely those who were diagnosed in the pre-TKI era to have cardiovascular death compared to the TKI era. And the p-value is less than 0.05. So then we were thinking about, since this disease, patients on this medication for many, many years, although there are trials looking at, if we can stop the medication at some point, we were still thinking, so when do this, mortality, the death actually occur? Did they occur early, or did they occur later during the course? So we divided by year of follow-up. We look at 2-year follow-up and then at 10-year follow-up. So if you look at the 10-year follow-up, there are actually no significant difference. The p-value is about 0.6, regardless your age. At any age group, there's no difference in terms of the cardiovascular disease specific mortality, pre-TKI versus TKI. But if you look at the 10-year follow-up, there are actually a significant reduction in cardiovascular death in the TKI era, about 32%. And then this is mainly occurred at younger age before 44 years old. So, and then this is just looking at the gender difference, because in the previous literature, there has been suggested that males, in a lot of heme malignancies, male has a worse outcome than females for some reason, including genetic, environmental, baseline profile. Males tend to have, more like to be smokers. They have more baseline comorbidities. So we were looking at males compared to females in pre and TKI era. So basically, if you look at this tables, you find that actually in the pre-TKI era, there's no difference in terms of male versus female. They're the same. They're about the same. However, in the TKI era, males observe a significantly increase in cardiovascular mortality compared to females, about 44% more, and the p-value is less than 0.5. So this is another outcome we will look at. Basically, we compared the pre-TKI and TKI era to the general population. So regardless, whenever you're diagnosed, if you have CML, you are more likely to, you have a higher risk of cardiovascular mortality compared to the general population. You look at all those numbers, they're above 1. But if you look at this overall, actually the blue is the pre-TKI and the red is the TKI. You look at actually the pre-TKI era patients, they have a higher standard mortality ratio compared to general population relative to the TKI era diagnosis. So conclusion, so in this study, we observed a decreased cardiovascular mortality among CML patients who were diagnosed in the TKI era in comparison to the pre-TKI era. However, they still have elevated mortality than the general population. So our results argues for further attention to among CML patients, especially male, elderly, to kind of, pay attention to their baseline cardiovascular risk factors and then close monitoring while they are on this TKI drugs. And then further investigation into specific mechanism and risk factors in the TKI-treated CML patients is really needed in the future. That's it. Thank you.
Any questions, St. Luke's?
Do you have any historical data on smoking, drinking, hyperlipidemia, obesity on your entire cohort of patients? Because those are the major factors contributing to cardiovascular risk, regardless of whether you have CML or not, except you don't untreated CML, you die anyway before cardiovascular risk becomes manifest.
Yes, thank you. So the question is, do we have any historical data on this population regarding their baseline lifestyle, their comorbidities, especially cardiovascular comorbidities? So unfortunately, in our analysis of the SEER database, they don't really have the baseline comorbidities. Especially their, diabetes, hypertension, we don't really have this data. But from the previous literature review, we found that patients who were diagnosed with CML, they tend to have more baseline cardiovascular comorbidities. And actually, after they are diagnosed, they start treatment, this cardiovascular, hypertension, hypovolemia tends to get worse. Yeah, so that's kind of what we found while we were doing the research. Not sure if this answered your question.
Dr. Chen, I just want to point out two specific drugs in development, and I think one of the known side effects of these two drugs is cardiovascular events. And it's higher, it's labeled as an adverse effect. So if we can single these two agents out during the development of this study, I think that would be even better.
Yeah, thank you. So the question is, can we, specify these two medications, nilotinib and ponatinib, which has the highest cardiovascular profile? So, so this study is, as I said, is here. So they don't specify the specific treatment, like the name of the chemotherapy. They only give you the time and the treatment, yes versus no. So it's very hard to specify which medication. But what we actually did is that we analyzed the data by time. For example, ponatinib is approved in 2012. So we can actually just see the combined effect of this newer generation's medications by their time frame. That's it.
So our next presenter is also going to be one of our graduate students. So Dr. Olu Adeosi is going to present a poster that was presented at the Society of General Internal Medicine this month actually in Washington, D.C. This is under the mentorship of one of our associate program directors, Dr. Goldberg. So she is a graduate of Warwick Medical School. We are very, very lucky. I don't know how many times to say very, very lucky to have her stay on as one of our faculty. She's going to be joining the Mount Sinai Doctors Faculty Practice at 147th Street up in Harlem. So I will welcome. I will welcome Dr. Adeosi to come up, and so she's going to present improving mental health care appointment show rates at an urban primary care training site.
Thank you, Dr. Osorio. It's a full house. I'm Olu. Everyone calls me Olu. I'm in the third year. Excited to be graduating today. Thank you to Dr. Goldberg, who I don't think could make it today, and all of the leadership who's helped me along to get to this point. So when I was thinking about a topic, I'm in the primary care track, and I was thinking about a topic to work on, and I chose mental health. I'm based at the Ryan 97 clinic, and in my experience, I think that if we do not adequately manage or treat the patients with commonly what we see as depression, anxiety, these patients are less likely to comply with anything else you tell them. If a patient is depressed, if a patient is anxious, you don't treat it, you wonder why the blood pressure is not controlled, why the diabetes is not controlled. They're not in the right state of mind, and I think those patients are less likely to care about their metformin or their insulin. So I think this was a very important project to work on. And so what I looked at, we're lucky at 97th Street to the Ryan 97 clinic to have behavioral health integration services available. Not all the Ryan clinics have that there every day. We have it every day. And I wanted to look at how familiar our residents are with the collaborative care model, which is an evidence-based model that is used for the management of patients with depression, anxiety, and other mental health diagnoses. And I wanted to see how familiar they are with that, and also how familiar our residents are with the referral process to BHI, the BHI service at Ryan 97. And then the second thing I wanted to look at was how can we improve our patient show rates for their BHI appointments. So the BHI team at Ryan is the team that basically offers more like the therapy, counseling services as part of the treatment, say for depression, anxiety. They liaise with the psychiatry team, and it's a benefit to have them there. But looking at the initial show rates, when I spoke to our team lead there, the show rates for appointments is something less than 30%. So we refer these patients, but they're not coming. They come and see the residents, but when you send them to BHI, they come back and they've not made the appointment, or they haven't showed up, and the question is, why are they not going, and how can we improve it? So just briefly about the collaborative care model. It's an evidence-based model that has been shown to improve health outcomes for patients with mental health disorders. It involves a multidisciplinary team that involves a primary care provider, the BHI professional, like I mentioned, a care manager, and a psychiatrist. And basically what the evidence has shown is that when you have this MDT team approach, that these patients are better managed and they're more likely to have favorable outcomes. And just again, the essential pillars of this model is that it's team-driven, it's population-focused, like it says, measurement guided. So when these patients come, you're reassessing the PHQ-9s to see how they're doing, and it's all, again, evidence-based. And I wanted to see how much our residents knew about this model, or if they knew that it existed. And just briefly about what we did, I just took a 3-month period. I looked at data over a 3-month period, looking at the BHI referral, the method of referral, and how that correlated with patient show rates. I also surveyed residents specifically based at 97th Street. So we do have 3 Ryan sites in Chelsea and also in Harlem, but I looked just at the 97th Street site about their knowledge of the collaborative care model and also the BHI referral process at the 97th Street practice. And then I'll talk in a future slide about the interventions that we did in this project. Just briefly about what the warm handoff is. Some of you may know about it, some of you may not. So at the time that we make an EMR referral on ECW, which is the EMR that we use at the Ryan Center, the warm handoff is basically where the resident contacts the on-site BHI team member at clinic just for a brief 5 to 10 minute hi, hello, introduction with the patient, and then they schedule an actual follow-up appointment. And I wanted to see whether having that brief interaction actually improves patient show rates, if meeting that BHI team member will make the patients more likely to come up for an initial appointment. So what I found when I surveyed the residents, I just took 2 main findings, were that majority of the residents were not confident about their knowledge of the collaborative care model. So, 42% were not at all confident. 26% were not so confident. And again, remember, this is just at 1 Ryan site. And this is important because if we're managing patients with these diagnoses, but we are not very knowledgeable about the fundamentals of the management process, then I think that's very significant and something to work on. The second thing I found was that a lot of residents were not very confident about actually how to refer to BHI. And again, it was, I guess, a reminder of what to work on in terms of educating residents, and also just working on making them aware of the process of the referral. And that's things we worked on with this project. Briefly about the interventions, just very simple. We introduced or made sure that we said 97th Street when we had our pre-clinic huddles, so it's like a 15-minute session in the morning or the afternoon before we start seeing patients. The BHI professional on site that day usually will attend the huddle, introduce themselves, and I think just to make the residents aware of who's on site that day for warm handoffs, and how to contact them. Distributing a how-to guide of how to communicate with BHI and also how to refer patients, and also just a sheet about the collaborative care model to educate the residents. In terms of the How to Provider Guide, I think that was important because a lot of times, and in my experience initially, when you refer patients to BHI, you get answers like, I don't want to speak to a therapist, I don't want to speak to a shrink, they've had negative experiences in the past, and I think some of that comes down to motivational interviewing, is how to engage patients to make them know this is an important part of the treatment, not just taking Lexapro or sertraline. And the same way I would refer a diabetic to a diabetic educator, it's the same way I would refer my depressed patient to BHI, and just destigmatizing it, I guess. What I found with my results in terms of the patient show rates was that most of our referrals at Ryan 97 to BHI were mostly just EMR. You click the referral on ECW and that's it. And our patient show rates when we had just an EMR referral were less than 25%. But whenever there was a warm handoff and you had that interaction with the BHI team member, of which the referrals where we had a referral and a warm handoff were less, but when it did happen, the patients were more likely to turn up for their appointments. And I think what this highlights is just a very small project, but I think what it highlights is that when the provider engages, or when providers engage, be it the doctor and BHI, that our patients are more likely to engage with care. And I think that, having our BHI staff present at 97th Street at the huddles and making the referral process more streamlined so that the residents know who to refer to, I guess, helps improve the flow. So things that I hope to, thankfully I'm staying on and to work on is working on a didactic session just about motivational interviewing, how to engage patients, how to get buy-in from the patients, a follow-up survey of our residents. And I think one of the important things that this project highlighted when we were trying to collect more data before I went to SIGM was that there was inconsistent recording of the warm handoffs from the side of the BHI team, and so we had difficulty obtaining subsequent data. And actually, I think that there was under-recording of the number of warm handoffs that the residents were actually doing. And as a result, that's something that the BHI team now is working to rectify so that there's more accurate recording, and I hope to follow up on it and collect more data to see how we're doing. And hopefully work on expanding this to the other Ryan sites, and I smile because there's been some changes in terms of the warm handoff situation, but that's something we hope to work on. Thank you.
Any questions at St. Luke's?
Did you compare the rates of appointment maintenance in the general clinic versus the mental health clinic? Because if they have a history of not coming for appointments, then there's even less likelihood they'll attend a mental health clinic. The other is, have you looked at socioeconomic features? For example, a woman with children and to pick them up from school, they have other events that will limit their ability to attend or who come to their regular appointments. So there are so many factors that go into this. And I found that sometimes the stories are heartbreaking because of limitations in their disease process also limits their ability to get there. And is there transportation support, for example, to keeping their appointment? So there's so many other factors. I couldn't agree with you more that unless we look at these factors, and one other is the substance abuse as another factor for the reason the mental health requirement is needed, and that's why we have medical office to begin with.
Thank you, Dr. Wong. Excellent question. In terms of comparing the general appointment show rates to the mental health, that's not something I've looked at, but I think that's a great point. In recent times, I think the show rates, at least to the resident clinic, I would say have had an uptick just from my experience, but I think that's something to look at. We do have, I guess, maybe probably a higher no-show rate than maybe a private clinic because our patients are more underserved, have, like you mentioned, other challenges. They have kids, no childcare, transport, but that's an important thing to look at. And the second thing, yes, I did not look at the socioeconomic status or barriers that these patients have, but that's something else that I think is a good point to raise and an area to look at, because I think there's more than one reason they're not turning up. They have other challenges that they're working with that impacts their appointments show rates.
It's like the Norma and Samuel show.
Bring it on.
You know, it's interesting to me, Olafunk, there's competing trends in healthcare, and so this to me goes back to an earlier era of healthcare where there was more of interactions. But you know, I think it's important for us to understand your thoughts around other ways of completing a warm handoff. And do you think, for example, a video handoff would be sufficient? Do you think a telephone handoff would be sufficient? Or do you believe, based on your data, and just, you know, I know you've thought about this a lot, it really has to be that in person?
I think a video, maybe. I don't know about a telephone. I think having that human interaction and that face-to-face contact makes an impact with patients. I have patients who say to me, all I have to do is see them for 5 minutes and know if I'm going to like them or not. Or just I guess the vibe, for lack of a better word. So I think having some kind of face-to-face and look at the face of who you're talking to would probably make an impact. Video, if we don't, like, say, some of the other clinic sites that don't have a BHI staff member present every day, sometimes like once or twice a week, I think, at Thelma, video is an option if we have the resources to afford it. But I don't know about telephone, but that's something to look at. Thank you.
Thank you, Olu. Thank you very much for that. I just wanted to say you can continue this at 1:47.
Yes. Thank you, Dr. Mack.
I want to just add one more comment, and that is without trust, there is no compliance. And without face-to-face, maybe Skype rather than video, you don't develop. I call it nonverbal communication. That's very critical. Even how you say what you say to the individual makes such a difference in giving that patient time to tell you what some of the barriers may be.
Thank you. So our next presenter is going to be Dr. Mohammed Gandhar. So he's going to present a poster that he presented at the American Thoracic Society this past week, actually, in Dallas, Texas. So they use pulmonary arterial hypertension-specific therapy and diffuse parenchymal lung disease with severe pulmonary hypertension, a systematic review and meta-analysis. So this is under the mentorship of one of our own faculty, Dr. Dejuhat. So Dr. Gandhar is a University of Manchester School of Medicine graduate. He'll be inducted in AOA next week. I just want to kind of put a plug in about that. So we're very proud of him. He will be applying for a pulmonary critical care fellowship this year. So Dr. Gandhar, he's one of our second years. Come up.
Good morning, everyone. I'd like to reiterate what all my colleagues said in terms of showing our appreciation to the whole residency program and our colleagues, of course. So as Dr. Osorio started off, I'm going to be talking about pulmonary hypertension therapy. And my interests mainly lie in sort of interstitial lung disease, and Dr. Shujat's interests are in pulmonary hypertension, so there was a common grounds to look further into it. And the main idea behind that is that people with interstitial lung disease can often present with pulmonary hypertension. And the question sort of raises itself in terms of whether there might be any benefit of treatment of this pulmonary hypertension. As you might be well aware, there's been a lot of advancements in the treatment of pulmonary hypertension with the onset of a whole array of different treatments now labeled as pulmonary arterial hypertension specific therapy, where there's interaction at the cellular level to hopefully adjust the different pathophysiological mechanisms in order to improve the pulmonary arterial hypertension. There hasn't been a lot of data in that regard or trials. However, some people initially tried treating such patients, and there's been some conflicting results. So we tried to collaborate all these data in order to see whether there's a better understanding of treatment of such people. Just a quick recap on the diagnosis of group 3 pulmonary hypertension. It basically is people with either lung disease or hypoxia that develop a mean pulmonary arterial pressure of 25 or above, or pulmonary vascular resistance of 3 Woods or more than 240 dynes. They also require to have a pulmonary arterial wedge pressure of 15 or less. In terms of severe, the parameters are slightly different. These are 35 or more in terms of mean pulmonary arterial pressure, or they have a mean arterial pressure of 25 or more with a reduced cardiac index of less than 2. Just a quick note, the recent World Organization Symposium, the 7th congregation, recently changed the parameters for pulmonary arterial hypertension definition and reduced the arterial pressure down to 20, so above 20. Thankfully for us, it didn't affect our research much because we were looking at the severe end of it. So that alteration didn't alter our findings. What we tried to look is search through the literature that basically looked at our population. Our main inclusion criteria were those who had diffuse parenchymal lung disease. This is a more unifying term for patients with interstitial lung disease. The studies had the requirements for us in our studies that they had at least 5 participants with pulmonary arterial hypertension specific therapy on board. They required to have an invasively diagnosed pulmonary hypertension, meaning that they should have a right heart cath. A lot of people are labeled as having pulmonary hypertension based on echo findings. However, these need to be corroborated with a right arterial heart cath as a gold standard because of variable findings with transthoracic echocardiogram. And they should have fulfilled the criteria for severe pulmonary hypertension. We also required some kind of follow-up measurements, either hemodynamics or a 6-minute walk test, to include them in the study. We used the open meta-analysis software, and we used some fancy worded model to look at the effect of therapy. So basically, we found around 360 citations in terms of using the PRISMA protocol. 360 citations were evaluated. We ended up with 70 abstracts that we reviewed. From these 70 abstracts, 40 articles were actually looked at in depth. Afterwards, we had to exclude around 32 for various reasons. Most of the time, it was because the pulmonary hypertension was not confirmed invasively with a right heart cath. That was the main limitation in most of the studies. And we ended up with 8 studies that we included in the analysis. This is a quick overview. I apologize for the color screen the color table. I tried to keep in the Mount Sinai color scheme, but then it didn't come up well on this. But from sort of the basic characteristics of the study, there was a total of around 208 patients that we included in the study. Most of them, only one randomized controlled trial was included. The other randomized controlled trials, unfortunately, didn't confirm the diagnosis with a right heart cath. And you can see that the majority had a very reduced DLCO. That's the measurement of diffusing carbon monoxide, which basically measures how well oxygen is transferred. It's a surrogate for oxygen transfer. And I should have put a fourth box, I'm sorry. So if you look at the FVC at the bottom, the majority of the patients, the pooled average for the FVC was 61%. So they all had restrictive lung disease. However, it wasn't profoundly as severe as the reduction in DLCO. This was our primary outcomes. Basically, we were looking at the pulmonary hemodynamics and the 6-minute walk test. As you can see, for the mean pulmonary arterial pressure, the cardiac index, and the pulmonary vascular resistance, they all, the people who were put on treatment had significant benefit from it. All p-values were below 0.05. However, when we looked at the 6-minute walk distance, unfortunately, there wasn't any benefit from the treatment. So hemodynamically, there was some effect. However, functionally, there wasn't, I wouldn't say a favorable, but there wasn't a pronounced effect that could be measured. Now, unfortunately, the 6-minute walk distance is not the best test for functionality in terms of patients, but this is what we can go by in terms of the studies that were provided. This is a quick overview of the forest plots for the different parameters. So here you can see them for the mean pulmonary arterial pressure and cardiac index, both showing benefit, either in the reduction of mean pulmonary arterial pressure by around average of 3 and improvement of the cardiac index minimally. Again, this here is the forest plot for the pulmonary vascular resistance and the 6-minute walk distance. As you can see here, if I can, with the pointer, the 6-minute walk distance, there was a trend to, if you can say, possibly a trend towards benefit. However, it sort of crossed the 0, so it wasn't significant after all. But I mean, just looking at this, you can see there's a very wide range of heterogeneity amongst the different studies, which was the main problem. So in terms of final points, we think that pulmonary arterial hypertension treatment probably has some role in terms of benefiting patients with diffuse bronchial lung disease. However, possibly the limitations is choosing the correct cohort of people to try this on. So I mean, most of the studies were not randomized controlled trials. That was one of the limitations of the meta-analysis. So possibly enrolling such patients in a randomized controlled trial might shed more light in the future. And just out of completion's sake, there's been recent articles and the symposium on this regard, most recently in March, where they published very similar findings in terms of taking patient-specific treatment protocols rather than an overall recommendation. So that's all. Thank you very much.
Any questions?
Did you show or collect any data on the degree of hypoxemia of these patients and the correlation with the pulmonary arterial pressures, and then the change thereof, and that they maintain their oxygen supplemental therapy? The other is all of us, in fact, we hyperventilate during sleep, especially during REM sleep. So if you're starting out hypoxemic and get a lot worse, so is there any history of nocturnal hypoventilation that contributed to the level of pulmonary vascular disease?
Sure, thank you very much for the question, Dr. Brown. I had a feeling that you were going to ask me this. So I was going to prepare a slide, but then the faculty told me that I have a 6-slide limit, so I didn't include it. However, we did look at the hypoxemia, and one of, as you might be well aware, one of the side effects of these treatments is hypoxemia. However, in our study cohort, the studies that actually sort of presented results on hypoxemia, there wasn't any significant reduction post-treatment. In fact, it stayed the same. And in terms of the hypoventilation, there wasn't any recording on that. However, what I can tell from the studies that I reviewed, most of these patients were severely limited at presentation and at enrollment in the studies. So they were all on, well, I would say, like just off the top of my head, around 80% of the patients were on supplemental oxygen, using it at least around 14 to 16 hours per day. So I would presume there might have been some hypoventilation associated with it, but not to the degree that would affect the results. I don't know whether that answers your questions.
Two quick questions, Mohammed. One, I'm just curious if you or Dr. Shujat were able to hypothesize about the asymmetric DLCO decrease. And totally unrelated question, but just a comment. Trend really is towards study designs that include patient-reported outcomes. And I would just affirm your comment that a 6-minute walk test really doesn't tell us much about the patient experience and what thoughts you might have about how to design a study in the future that might get at the patient experience of the treatment.
Yes, two very valid questions. So, actually forgot what the first question was.
It's so valid.
Because I was more interested in the second question. My true intention. So actually, this asymmetric DLCO to FVC is something that's been in the literature, around in the literature for a while, and the hypothesis goes that although we think that the main reduction in the DLCO is secondary to the lung disease, if I can pull quickly the baseline characteristics, you can see that a lot of the patients here have a connective tissue disease underlying disorder as well, and the hypothesis goes that there might be actual sort of vasculature changes that cause the further reduction in DLCO, irrespective of the lung disease itself, and that's why people are more prone to treating these patients, thinking that there's vasculature involved. Now on to the more interesting question of the two. In regards to better testing, unfortunately it's very difficult. However, one better test, I think research is a lot of the time restricted by numbers and by significance. However, I think there are two other parameters that are very important. One is the subjective feeling of the patient. I mean, maybe there isn't a pronounced increase in the 6-minute walk distance or the functionality of the patient, but subjectively they might feel better, they might be sleeping better, they might be talking better. So a valid test might be just the basic WHO criteria for dyspnea. And some of the studies actually had reported on it, but there wasn't consistent reporting in terms of us being able to extract the numbers. Secondly, they can undergo a more robust testing of sort of a cardiopulmonary, full cardiopulmonary testing, where they're taken to the lab and they're put on a treadmill and they're put on different measurements for their lung function and their heart rate. That could be something in the future. And what more sort of the Bohr index, some people have taken in the Bohr index, which is mainly for COPD patients, where they include the WHO, the 6-minute walk distance, a multitude of different variables together to come up with maybe a better overall functionality rather than just a 6-minute walk distance. Unfortunately, there isn't a gold standard for us to measure upon, so everyone takes it on themselves. But I think subjective quality of life, I think these are possibly more tangible things to target.
I'd like to comment on that dysynchrony between the forced vital capacity and DLCO. The forced vital capacity depends on not only the lungs, but the ability to stretch the lungs, which the respiratory muscles and many muscles from the nose to almost to the toes can contribute to the forced vital capacity. So you're very strong. You can pull a rubber band a lot farther than if you're very weak using the same rubber band. But the DLCO doesn't measure the same thing. It measures the ability to transfer carbon monoxide across a vascular bed per unit time. Now, CO has such affinity for hemoglobin that transfer occurs much more rapidly than even oxygen because the affinity of hemoglobin for oxygen, for carbon monoxide. So it's that transfer factor that's truly what you're measuring. And that's also a function of the ability to get the measuring agent to all the spaces which are widely distributed to be uniform. The heterogeneity of the underlying diffuse rate that you may not be getting your indicator to the space and the time it's allotted to transfer. So membrane transfer factor. So clearly that doesn't depend on how well you stretch the rubber band, but how well you get your indicator to the area where the rubber band is. So that's why there's a synchrony. But the synchrony, the lower the DLCO, the higher mortality. So it's not surprising that the fewer vessels you have to carry oxygen to the whole body is limited, therefore, to how long you can live. We don't do it all the time. The other factors, looking at the quality of life, St. George's questionnaire might be another way to get at this. But again, that is a subjective assessment, but at least that's been standardized.